So thanks again for the opportunity to present. Happy to be here. This morning I'm going to be talking about an update on reducing residual atherosclerotic cardiovascular disease risk. These are my background disclosures. I think the most pertinent disclosure I should make is actually a number of the clinical trials that we'll be talking about this morning. I was fortunate to be a principal investigator on, and that obviously needs to be disclosed because it does mean that I bring bias to the presentation. I take a lot of ownership over some of the data that we're going to be talking about, but hopefully that also provides a little bit of insight because I was involved in some of these trials, and that can lend itself to understanding a little bit of the nuances of what the trials and how they apply to specific populations. The other thing that I want to just take this opportunity to highlight is we have been selected at the Cambridge Cardiac Care Center and to represent our hospital in the ACT network, the Accelerating Clinical Trials Network. Dr. Lagasse and I have spoken about this. So this is a network that has been put together by the federal government, led by PHRI at McMaster University, to create centers of excellence across the country to accelerate clinical trials and to more effectively have Canada participate in clinical trial development and implementation, particularly for in-hospital clinical trials that sometimes are more difficult to do. So it's really great to have been chosen to be a part of that, and I look forward to working with Dr. Lagasse and some of the other hospital-based physicians as we try to further augment clinical trial participation in our city and the region. So to begin with, when we talk about ASCVD, we no longer really refer to this as CAD like we used to before. We really talk about this as ASCVD, or atherosclerotic cardiovascular disease. And the reason that we've broadened that scope is that we've really learned, and I think we knew for a long time, but certainly the data consistently shows that this is a systemic process. Atherosclerosis that occurs in the coronary bed that I focus in on is really the same process that leads to atherosclerosis in the cerebrovascular and as well as the peripheral vascular beds. And we know that this disease state extends across the polysystems because patients who've had a myocardial infarction, for example, are at a significantly higher risk of having a stroke or TIA. Similarly, patients who've had a stroke are at a very high risk of subsequently developing coronary artery disease. And among the highest risk, in fact, are peripheral vascular disease patients. They are the highest at risk for developing coronary artery disease and strokes or TIAs. And one of my mentors in Toronto always said to me, a peripheral vascular patient doesn't die of their peripheral vascular disease, they die of their MI. And so we know that we need to be very systemic in our approach. Fortunately, we've also learned that the risk factors that lead to coronary artery disease are similar risk factors that lead to cerebral vascular disease or peripheral vascular disease. And fortunately, the interventions that I may deploy for my coronary artery disease patients has significant benefits for patients with cerebral vascular atherosclerotic disease or peripheral vascular disease. So that's actually really exciting that our interventions that we apply to one bed may have benefits in other beds of vascular disease. But certainly this is a disease that is systemic in nature and is very prevalent, as we all know. Worldwide, it's estimated that in 2020, over 500 million cases of cardiovascular disease existed, and 19 million people died of cardiovascular disease in 2020, the most recent data that I was able to find. It's responsible for 1 in 3 deaths above the age of 35 worldwide, and it progresses in all vascular settings. So peripheral vascular disease continues to progress and becomes more systemic, and similarly, coronary disease progresses and becomes systemic. 40% of Canadians have at least one risk factor for developing CVD, and more than, or over 40% actually have more than 3 risk factors. In Canada, every 7 minutes, someone will die of heart disease or stroke, and during this presentation, there will be a number of Canadians that will die of a disease that we should be able to prevent the vast majority of, and we need to be more aggressive about that prevention strategy. Stroke, similarly, is the leading cause of adult disability in Canada and the third leading cause of death in Canada. So this is very much a systemic process that we need to be very aggressive about preventing. At least in the coronary disease population, patients who've had an acute coronary syndrome, the vast majority end up having an invasive evaluation during their incident admission when they're admitted for an MI and STEMI, or unstable angina. The vast majority end up having angiography. And we know that an early invasive interventional strategy reduces recurrent infarction, CHF, arrhythmia, and long-term mortality. When I was doing my training at U of T, we would often go through strategies. Well, let's do a stress test. We'll send them home. We'll decide subsequently if we want to do a cath or not. Now, the vast majority of patients will end up with angiography during their incident admission, and we know that an early invasive strategy versus a more conservative non-invasive strategy, invasive interventional procedures, reduce recurrent events and mortality in the short term. But looking past that immediate management, we really have to think about this as a progressive chronic disease that we need to have long-term prevention strategies for. And when we think about prevention strategies in ASCVD, we really try to put them into different bundles of intervention. We know that lifestyle and healthy behaviors are a key to chronic disease management in most chronic diseases, and certainly in ASCVD is really the hallmark of how we need to approach atherosclerotic prevention. And that can focus in on cholesterol reduction, good blood pressure control, and there are specific agents that we know are more efficacious than others at ASCVD event reduction. And certainly in our population of an obesity epidemic and diabetes epidemic, effective glycemic management, diabetes management with agents that reduce cardiovascular events is essential. As you know, the Cambridge Cardiac Care Centre is one of the regional cardiac rehab programs and a divestment from Cambridge Memorial Hospital. And our approach, and I think cardiac rehabilitation, is central to the management of ASCVD patients. When we think about cardiac rehab, people will often think, oh, it's a gym, I can just go to a gym anywhere. Cardiac rehab is much more than a gym. As you know, it is really a chronic disease management program that focuses on patient support, self-support, education around cholesterol and blood pressure and sugar management, weight management strategies, dietary counseling. Obviously, there's on-site exercises that patients participate in, but they do have guided exercises at home. And for patients that cannot come on site, either because of distance or travel restrictions, virtual cardiac rehab in this era of virtual medicine at times has allowed us to reach a larger number of patients that in the past couldn't participate in cardiac rehab. Certainly smoking cessation, which I'll talk about briefly, is an essential component of that. And we know that cardiac patients and ASCVD patients suffer from mental health conditions, and depression and anxiety is incredibly common in the ASCVD population. And so support and guidance and management of depression and anxiety is a central component of cardiac rehab. So we really think of cardiac rehab as a coordinated strategy for secondary prevention of ASCVD. Cardiac rehab has been well studied, and patients that participate in cardiac rehab have a significant 20 to 25% reduction in cardiac death, rehospitalization, or subsequent need for revascularization. As we talked about, depression and anxiety is very common in the ASCVD population, and participation in a coordinated cardiac rehab program does help to reduce depression, accelerates return to work after an acute coronary event, and cuts recovery time in studies by as much as 50%. So certainly a strong proponent of trying to ensure that there's effective access to cardiac rehab across our region. An important component of cardiac rehab and ASCVD management in general is encouraging and supporting patients on their journey of smoking cessation. Every study that's ever been done looking at smoking cessation with any support systems that can be deployed has consistently shown a significant benefit of smoking cessation after an ASCVD event. Patients that quit smoking after an event have almost a 50%, 45% lower risk of mortality compared to persistent smokers. And that's front-loaded. Very quickly, mortality starts to drop with as much as a 20% reduction within 4.5 years. It takes as little as 13 patients to quit smoking to save one life. There's really no intervention, not revascularization, not statins, no therapy that we can think of that has an NNT as little as 13 to save a life. So it is certainly an important aspect of ASCVD management. It is challenging often to get patients to quit smoking, as we all know, but studies have actually shown, it takes patients as much as 6 to 7 attempts to quit smoking. But each attempt actually has benefits. So there was actually a very interesting study out of, I think, Stanford that showed, patients that make an attempt at quitting smoking, even if they don't quit, but they continue to make that attempt, have reduced cardiovascular events. And it's likely because each time they're smoking a little bit less, and each effort, and we know that every cigarette they smoke less of does reduce cardiovascular events. So while it can be frustrating to continue to try to encourage patients to quit smoking, I think that's all of us should continue to encourage patients and give them the support they need to continue in that journey for smoking cessation. Beyond lifestyle intervention, though, we know that pharmacological management of ASCVD is essential, and there have been really a 4 or 5 pillar approach to ASCVD management. The Canadian Cardiovascular Society a number of years back created the ABCD management strategy for ASCVD, where we think about antiplatelets as one of the A's, ACE inhibitors or ARBs, beta blockers, cholesterol reduction therapies, and diabetes optimization. I'll talk briefly about all of those and then talk about more novel therapies later on in this presentation. But certainly aspirin has been a hallmark of ASCVD management and CAD patient management. And we've studied aspirin actually across a various range of doses, from high dose aspirin to very low doses of aspirin, down to less than 75 milligrams, as low as 65 milligrams. And across consistently up to that level, there is consistent benefit. And there's no evidence that higher doses of aspirin have greater benefit than lower doses. And so the vast majority of patients, after maybe an initial loading during their incident event, end up, at least in the Canadian system, around 80 to 81 milligrams of aspirin. There was a recent study that actually looked at coated aspirin versus uncoated aspirin and showed really no difference between that, either in ASCVD events, or interestingly, the coated aspirin group did not have lower GI bleed risk versus those that were on uncoated aspirin. Coated aspirin does tend to be a little bit more expensive, and it is not covered by anti-drug benefit for some reason. And so as a result, in patients, that sometimes even that small cost of aspirin can sometimes be a barrier. Now that data is out that coated aspirin does not necessarily have lower bleeding risk, I'll often tell patients they can just take even a 325 and just cut it to get it down to that low dose if cost becomes a barrier for them. Beyond aspirin, we know that the second pillar of ASCVD management is the use of ACE inhibitors or ARBs. Well studied really across a spectrum of ASCVD patients, both in ASCVD patients that end up with LV impairment and heart failure. Obviously, huge benefits from RAS modulation, and ACE inhibitors were one of the pillars of heart failure management and ischemic cardiomyopathies. Now we have more effective therapies beyond ACE inhibitors. ARNIs or Entresto, sacubitril/valsartan may be more efficacious than ACE inhibitors alone. But certainly managing RAS or modulating the RAS system, renin-angiotensin-aldosterone system, is essential in heart failure management. But even in ischemic heart disease and ASCVD that does not result in an ischemic cardiomyopathy or heart failure, still has significant benefits from getting patients started on ACE inhibitors or ARBs, regardless of LV function and regardless of presence or absence of an ischemic cardiomyopathy. So across really the spectrum of ASCVD, consistent benefits from early initiation of ACE inhibitors or ARBs, regardless of blood pressure. Even patients that are normotensive still benefit from RAS modulation and initiation of ACE inhibitors. Beta blockers have been used for many decades now after an MI. In the acute and subacute setting up to 2 years, beta blockers show a consistent mortality reduction. Those that end up with an ischemic cardiomyopathy and heart failure, carvedilol may have greater efficacy, at least in comparison to metoprolol. But carvedilol, as you know, is a very potent antihypertensive, and sometimes patients can't tolerate that high a dose of carvedilol. Bisoprolol is more cardioselective, and patients with, for example, COPD may be able to tolerate that a little bit better than less cardioselective beta blockers. So the data around beta blockade after an MI is consistent for mortality reductions at least up to 2 years. Beyond 2 years, there is equipoise and some controversy as to whether there's continued benefit from the use of beta blockers if there is no LV impairment. If they don't have heart failure and ischemic cardiomyopathy, is there still continued benefit from beta blockade? Some debate around that, and really a lack of good data to really guide us on that. And so I tend to individualize that, see how the patient's doing on it. If they're very stable with it, tolerating it, I may continue it. But if they're struggling with it, blood pressure's low, or they're really bradycardic, or struggling with the beta blocker with side effects, that can perhaps be rethought after 2 years. Statins, as we know, have been an important pillar of ASCVD, atherosclerotic risk reduction, and the more potent the statin, the lower the event rate. This was shown in the Prove It study, where patients were randomized to moderate intensity statin, pravastatin, 40 milligrams, versus a high intensity, high dose statin, atorvastatin, 80 milligrams. And we saw that those that were on the more potent statin at the highest dose had greater reductions of atherosclerotic events compared to those that were on the less potent statin. So certainly early initiation of high dose potent statins are an important part of ASCVD management to reduce events. And you can see from this curve that the event reduction starts to occur quickly within a few months, and the longer patients remain adherent to high-dose statins, the greater the efficacy and greater event reductions. Those have been really the pillars of ASCVD management for many a decade now, for 2-3 decades, and that's really been how we've managed these patients. Despite these 5-pillar approach to ASCVD management, we know, however, that there is a residual cardiovascular risk. The first year, events occur rather quickly, but events continue to accrue over time. Patients who've had an atherosclerotic event continue to have events despite being on that guideline recommended medical therapy. And if you watch these patients out to 3 years, for example, as much as 15% of them will have had another cardiovascular event, MI or stroke, despite being on antiplatelet therapy, ACE inhibitors, statins, or beta blockers. So we know that sometimes we need to go beyond these therapies and look at other interventions to try to reduce residual cardiovascular risk. So there have now been novel therapies to help mitigate that and reduce that risk. In 2020, the Canadian Cardiovascular Society came out with new guidelines on ASCVD optimization, and they've really talked about a multi-pronged approach beyond aspirin, beyond statins, beyond ACE inhibitors. So the first prong is to really try to optimize lipid reduction, and there are 3 therapies potentially in that group that we'll talk about. For LDL reduction, more recently, we have shown efficacy for triglyceride interventions with an agent, icosapent ethyl or Vascepa, that we'll talk about. Better glycemic therapy with specific agents that reduce cardiovascular events have finally become available, and they are now a therapy that we are recommending for diabetics with ASCVD, and more effective antiplatelet therapy in the long term we will talk about as we go through. So let's talk about LDL reduction beyond statins. Lipid optimization is essential. We know from trials like Prove It that we talked about, even with high intensity, high potency statins, while they do reduce risk by up to 16%, that means that there is still a residual 85% risk of recurrent cardiovascular events in the post-ACS population. And even in the stable CHD population from the TNT trial, Treat to New Targets trial, where atorvastatin 10 milligrams was compared to atorvastatin 80 milligrams, while the high intensity dose did reduce risk greater by as much as 22%, that still meant that there was still a 78% residual risk for recurrent events. So we clearly know that we need to do better. These therapies are efficacious, but not enough. The first LDL lowering therapy that showed any further event reduction beyond high intensity statins was ezetimibe. In the Improve It study, we were part of that trial and one of the larger recruiting centers in the trial. This was a very long trial. It took a very long time for ezetimibe to prove its mettle, and it had a relatively modest event reduction, but did reduce events. After 7 years of being on ezetimibe on top of statins, there was a 2% reduction in events. That's a long time and a relatively modest efficacy, but there is some benefit. So certainly in some patients, adding ezetimibe is certainly something we start to think about. And now that ezetimibe has been generic for a few years, the cost benefits start to accrue even more. But often that's not enough. And as you can see, despite being on statins and ezetimibe, there's still obviously a significant residual risk. All of this risk still persists despite this combination therapy. And so fortunately, we've started to understand more detailed what leads to further LDL persistence and events. And the central role of PCSK9 in that has come to the forefront in the last few years. So PCSK9 understanding is actually a Canadian breakthrough. This protein was first discovered in Canada, and some of the treatments that have been developed for PCSK9 abnormalities were developed in Canada. Much of the trials with PCSK9 inhibitors were done in Canada as one of the leading countries that developed these molecules. So, and we were fortunate to again be part of these trials. So Canada really should take a lot of confidence, and we should be proud of the scientists in the country that have really helped to move this forward. So talking about the biology of PCSK9, we all know that LDL is made primarily, 85% is made in the body, in the liver. So the liver produces LDL, it puts it into the bloodstream, but the liver also destroys LDL. There are LDL receptors on top of hepatocytes that capture the LDL. When the LDL is captured, it's internalized and then destroyed. Body has all sorts of feedback mechanisms for things, as you know. One of the feedback mechanisms is a protein called PCSK9. This is again a protein that's made in the liver. When it's circulating in the bloodstream, when the LDL is captured by the LDL receptor to be internalized and destroyed, PCSK9 binds to that complex of LDL and LDL receptor. So when the LDL receptor complex is internalized, PCSK9 ends up destroying the LDL receptor, so it can't recirculate back to the surface of the hepatocyte to capture the next LDL molecule. High levels of PCSK9 in the bloodstream result in very low densities of the LDL receptor on the hepatocytes and less clearance of LDL by the liver. Monoclonal antibodies were developed now a number of years back that can bind the PCSK9 protein itself, take it out of circulation, so it does not bind the LDL receptor LDL complex. So with taking the PCSK9 protein out of circulation, the LDL receptor LDL complex comes in without the protein bound to it. When the LDL is destroyed by the hepatocytes, the LDL receptor remains intact and can recirculate back to the surface of the hepatocytes. So we end up with a higher density of the LDL receptor on the hepatocytes. With greater density, we're able to clear more LDL, and the hepatocytes end up lowering LDL much more effectively. So very interesting biology discovered here, much of it in Canada, a lot of central work being done out of the Montreal Heart Institute, for example. The PCSK9 inhibitors are antibodies, and there are two commercially available, alirocumab and evolocumab. Both have very similar efficacies. We were again fortunate to be part of the development of both of these molecules at the Cambridge Cardiac Care Center. Both have shown very similar efficacy. I'll show you the data on evolocumab, but the similar data exists for alirocumab. Evolocumab was studied in Fourier. Evolocumab's brand name is Repatha. And what we saw in the Fourier trial is that this agent is highly efficacious on top of maximum statin therapy. The addition of evolocumab subcutaneously every 2 weeks resulted in a dramatic 60 to 65% further reduction of LDL down to very low levels below 1 millimole, and that reduction persisted with time. There was no loss of efficacy, so there's no weaning or waning of efficacy with time. LDL remains very low in those patients that are on PCSK9 inhibitors. And that reduction in LDL resulted in dramatic and early reduction in atherosclerotic events. The composite of cardiovascular death, MI, or stroke was substantially reduced. And you can see that the curves separate early within a few months. And again, the longer patients are on the PCSK9 inhibitor on top of high-dose statin therapy, the greater the efficacy, the greater the curve reduction. This trial was actually terminated early by the Data Safety Monitoring Board because they felt it was unethical to continue the trial and have patients on placebo when the PCSK9 inhibitors were so efficacious. So very consistent benefits, both with evolocumab and alirocumab as PCSK9 inhibitors. More recently, there's been really very interesting work done with what are called siRNAs, so small interfering RNA molecules. It's amazing that we're already at a point that we can manipulate RNA. So inclisiran is a small interfering RNA molecule that binds to the mRNA that produces PCSK9. By binding to that mRNA, this can help reduce the production of the PCSK9 protein. And remember, PCSK9 was that protein that ends up with the destruction of LDL receptors and hepatocytes. By reducing the production of the PCSK9 protein, LDL receptors are recirculated back to the surface of hepatocytes and end up clearing LDL efficiently through the hepatocytes, through the liver. This, as a mRNA or antisense mRNA, is given infrequently subcutaneously. The first dose is delivered, and the next dose is at 3 months, and subsequently patients get a subcutaneous injection every 6 months, so twice a year. And we see great efficacy with this agent as well by reducing PCSK9. In the Orion phase 3 trial, for example, inclisiran substantially reduced LDL on top of statin therapy compared to placebo, and that persisted as much as a 50% reduction with time. There was no loss of efficacy either. So in the phase 3 trial with inclisiran, or the brand name for that is Leqvio, very effective and persistent reductions of LDL. The ongoing outcome trials to look at the true mortality and atherosclerotic event reductions are all still ongoing. But in preliminary analyses of the pooled data, we did see significant reductions in cardiovascular death and atherosclerotic events. This is observational and hypothesis generating. These trials, the Orion phase 3 was not designed as outcome trials and mortality trials, so we really have to wait for the mortality and outcome trials with inclisiran to see its efficacy. But certainly the expectation is that it will have good efficacy as the PCSK9 inhibitors had, because of the persistent LDL reductions that we see with this agent. It's very well tolerated. Inclisiran has a very good safety profile outside of some subcutaneous, injection site irritation. No real adverse events compared to placebo. And the exploratory cardiovascular event basket was significantly less with inclisiran than placebo, but we're waiting for the outcome trial. So Leqvio and inclisiran is available in Ontario, and for patients that have persistent LDL elevations despite high-dose statins plus minus ezetimibe, we now have efficacy with both antibodies like Repatha and with antisense anti-RNA therapies like inclisiran. So very exciting that these therapies have become available. Even with a significant LDL reduction, so even when we get LDL to very low levels, we know that certain patients will continue to have atherosclerotic events due to persistent elevation of triglycerides. And as you know, statins and ezetimibe and even PCSK9 inhibitors have marginal or no real benefits for triglyceride reductions. In the past, therapies that reduce triglycerides fail to show any efficacy. So, for example, fenofibrate or all of the fibrates really have no atherosclerotic event reductions, and we do not use fibrates now in cardiovascular patients, at least for ASCVD event reductions. If they have very high triglycerides, we may use fibrates to reduce the risk of pancreatitis, but they do not reduce MIs or strokes. Similarly, niacin reduces triglycerides but failed to show any benefits in two very large trials that we were part of, the AIM-HIGH trial and HPS Thrive. And over-the-counter fish oil capsules, again, well studied in randomized trials, do not show any benefits. In fact, over-the-counter fish oil capsules, there's a lot of controversy now that they may increase the risk of atrial fibrillation in particular. And so we really discourage patients from taking over-the-counter fish oil supplements because they can interact and increase bleeding risk and really have no benefits for ASCVD event reduction. Fortunately, we now have a therapy, icosapent ethyl, or marketed as Vascepa, which on top of high-dose statin therapy in patients specifically with triglycerides above 1.5 significantly reduces events as much as a 5% absolute event reduction within 5 years of being on icosapent ethyl compared to those that were on placebo in the Reduce It trial. And so when you look at the 5-point MACE, major adverse cardiovascular events in this trial, there was a 25% relative risk reduction with a small NNT of only 21 to reduce an event by having a patient on icosapent ethyl or Vascepa on top of statin therapy. So with these various therapies for different molecules of LDL and triglycerides now being available, CCS, Canadian Cardiovascular Society, changed its lipid guidelines in 2021, and in secondary prevention of ASCVD, we now use a threshold approach to lipid management. What we mean by that is all patients with ASCVD should be on maximum tolerated statin therapy. Once they are on the maximum statin therapy, we should be rechecking their lipids. First, talking about the LDL component of that. If their LDL is above 1.8, we need to trigger further intervention. 1.8 is not the target. We're not trying to dial them down to 1.8. We want to use 1 point as a trigger point for adding the next pharmacological intervention. If their LDL is above 1.8 or the ApoB above 0.7 or non-HDL above 2.4, but most of all we'll use 1.8 as the trigger point. If the LDL is above 1.8, but only marginally above 1.8, say between 1.8 to 2.2, we may consider adding in ezetimibe on top of the statin, rechecking, and if it's still high, consider the PCSK9 inhibitor. But if it is significantly above 2.2, then we know that ezetimibe will not be enough, and there a PCSK9 modulator or inhibitor should be considered first, if at all possible, and then adding in ezetimibe. And there are fortunately support systems in place from the various companies that make PCSK9 inhibitors, and now inclisiran, the Cerna for PCSK9 reduction. And these support systems can often help to get some of these patients onto these therapies, and because they can sometimes be challenging as they are expensive therapies. So certainly we have very effective LDL reducing therapies beyond statins, and we need to initiate that if their LDL is above 1.8. In patients that have persistently elevated triglycerides above 1.5 when they're on statin therapy, again, as we've talked about, the Reduce It study showed great efficacy by the addition of icosapent ethyl, and the CCSK9, the CCS 2021 guidelines emphasize that in these patients that are on statins, if their triglycerides are above 1.5, we should be initiating icosapent ethyl at 2,000 milligrams twice a day. It is covered in Ontario by Ontario Drug Benefit, although you do have to fill out some forms to try to get it covered for the patients. It is covered if they've had an ASCVD event and are on statin therapy with elevated triglycerides. So that certainly gives us more effective LDL reduction. That does lead to a lot of interventions that need to be done, though, and we know that this can be challenging. In response to that, to try to get more patients to target, the Ontario Secondary Prevention Network was developed. This is a nurse practitioner-led initiative, and the Cambridge Cardiac Care Centre was one of the founding members of the OSPN network, with sites in Oakville, Hamilton, Mississauga, Niagara, and Kawartha. So really, and now more sites are being developed across the province. So this is really a secondary prevention network where nurse practitioners and nurses are central to trying to get patients to optimum therapies beyond statins, and making sure that they have access to these therapies, making sure that they have appropriate guidance and lifestyle intervention as well. And so this OSPN network has been in place now for the last 9 months. It's open to anyone to refer into, and we've seen a large number of patients through this network at the Cambridge Cardiac Care Centre. To date, across sites, over 2,600 patients have gone through the OSPN network intervention, and we've seen that with this nurse practitioner-led initiative, that we can significantly and dramatically improve the uptake of novel therapies to get these patients to target. In this preliminary data analysis of the efficacy of our network of OSPN, we saw that LDL in patients that first were referred to the program was as high as 2.9, despite being on high-dose statin therapy. But with lifestyle intervention and the introduction of these novel therapies that we've talked about, by visit 6, the LDL had come down from 2.9 down to 0.9. So very good work by this nurse practitioner-led initiative that can help to get patients onto optimum therapy. And if there are patients that you have in your practice that you think may benefit from that, it's certainly open for referral for anyone across the region to help guide these patients to optimum LDL reduction. We know that events, though, continue to accrue despite LDL reduction, despite triglyceride reduction, and that's always a question mark. How is that possible? You've got the LDL incredibly low, you've got triglycerides very low. What's going on? What we've also learned, though, is that there is a third atherogenic cholesterol moiety called LPA, lipoprotein A. This we've actually known about for a long time, but now more and more data coming together. This is a highly atherogenic molecule that has properties somewhat similar to LDL, but is purely genetically derived. Lipoprotein A, in fact, maybe more deleterious than LDL alone. It has two very harmful properties. It is pro-atherogenic, so leads to plaque buildup, like the LDL receptor, like the LDL moiety. But it is also prothrombotic, meaning that they will end up with clots and thrombus on the atherosclerotic site, more so if they have high LPA. So these two mechanisms of harm really result in patients that have elevated LPA being at a great risk of atherosclerotic events. And remember, LPA is purely genetically derived. The levels remain stable throughout the lifetime, meaning if you have an elevated LPA, you've had it your whole life from birth, which means you're really exposed to this atherogenic molecule for a very prolonged period of time. And studies show that patients that have elevated lipoprotein A are at a much greater risk of atherosclerotic events. In fact, lipoprotein A may account for 1 in 14 heart attacks. Interestingly, LPA may also be closely linked to the development of aortic valve disease and aortic stenosis, and 1 in 7 cases of aortic stenosis may be attributed to high elevated LPA. It's also a very common genetic disorder. 1 in 5 Canadians have the gene for elevated lipoprotein A. It's one of the most common genetic disorders in the country, and is a significant contributor to atherosclerotic disease progression. It is purely genetic. Lifestyle interventions like diet and exercise do not have any impact on LPA, and most lipid-lowering therapies are ineffective to lower LPA. Statins, ezetimibe, really have no impact on LPA. In fact, there are no approved LPA treatments, at least for now. PCSK9 inhibitors and modulators may reduce lipoprotein A 20 to 30%, although they do not have an indication specifically for that abnormality. There are now very exciting gene silencing therapies that are being investigated. We're fortunate to be part of some of those trials, looking at both reducing atherosclerotic events as well as reducing aortic stenosis progression. These gene silencing therapies in phase 2 trials have reduced lipoprotein A dramatically, as much as 80%. We now need the outcome trials that are ongoing right now to prove that reducing lipoprotein A will reduce ASCVD events. Those trials should become available in the next 3 years or so, but certainly very exciting research being done in that, and hopefully we will have a treatment for that. Certainly we know that there is a diabetes epidemic in North America and really worldwide, and we know that diabetes dramatically and rapidly accelerates ASCVD. You know, we no longer refer to diabetes as a cardiac risk factor. We refer to it now as a cardiovascular risk equivalent. What we mean by that is we know that diabetics that have had diabetes for as little as 10 years may be at a similar risk of an MI as those that are non-diabetic and have had a recent MI. So it really speaks to how much diabetes accelerates ASCVD. Historically, historical therapies like metformin and sulfonylureas really failed to show any efficacy in ASCVD event reductions. The granddaddy of diabetes trials, UKPDS, for example, showed really a lack of efficacy in traditional therapies. More aggressive glycemic control resulted in no significant benefits in the UKPDS trial, at least out to 10 years. And so as a result, most cardiologists historically did not focus on DM management because we really failed to see any benefits from traditional anti-glycemic therapies. Fortunately, there have been, as you know, great advances in DM management, and particularly the GLP-1 receptor agonists have shown great efficacy in ASCVD risk reduction. Both semaglutide or Ozempic or liraglutide or Victoza, for example, in their outcome trials showed significant benefits in cardiovascular event reduction in diabetics that were on semaglutide, for example, had significantly lower events, and those event curves start to separate again quickly. So GLP-1 receptor agonists show great efficacy in reducing atherosclerotic events in diabetics. There is actually now very good data that will be presented at the American Heart Association meeting in a few weeks in November in the SELECT trial that, again, we were fortunate to be a part of at the Cambridge Cardiac Care Center. In the SELECT trial, we randomized patients to semaglutide that were not diabetic but had ASCVD, had a prior cardiac or cerebrovascular or peripheral vascular event. And the trial was again stopped early for significant benefits from semaglutide in obese ASCVD patients. As much as a 20% event reduction, we're told in the press release. The actual data will be presented at the American Heart Association meeting. It is a featured presentation, meaning there's a lot of excitement in the cardiovascular world as to how GLP-1 agonists may be deployed in non-diabetics with ASCVD to reduce events. So stay tuned. But certainly in the diabetic population, we know GLP-1 agonists show great efficacy. Similarly, we have known now for a few years that SGLT2 inhibitors show a significant reduction in heart failure and CKD progression in diabetics with established cardiovascular disease. This was first demonstrated in the AMPA-REG trial, where empagliflozin in patients that had a history of ASCVD, empagliflozin significantly and rapidly reduced the risk of heart failure and CKD progression, and that curve continued to separate with time. So as a result, both the Diabetes Canada and the Canadian Cardiovascular Society strongly recommend the use of SGLT2 inhibitors and GLP-1 agonists as preferred anti-glycemic therapies in patients with ASCVD. These two classes of drugs may be very synergistic. SGLT2 inhibitors reduce heart failure and renal disease progression in ASCVD patients, have minimal impact on atherosclerotic disease. GLP-1 agonists reduce atherosclerotic disease progression and ASCVD events, have modest effects in heart failure, although there is now good data coming out in heart failure with preserved ejection fraction with GLP-1 agonists. But certainly the combination can help to retard both the progression of heart failure as well as ASCVD disease progression. So certainly SGLT2 inhibitors and GLP-1 agonists should be a mainstay of anti-glycemic therapy in diabetics with ASCVD, in preference to older therapies like sulfonylureas or DPP-4 inhibitors that should be used less and avoided if possible, preferring these agents in diabetics with ASCVD. Some patients require more effective antiplatelet therapy beyond aspirin. Aspirin does have efficacy, but may not be enough. We certainly know that within the first year, patients need to be on dual antiplatelet therapy if possible. This was first demonstrated in the CURE study from McMaster, led by Salim Youssef. In the CURE study, we saw that patients that were on clopidogrel or Plavix plus aspirin had significant 20% relative risk reduction compared to those that were just on aspirin alone out to a year. This did come with a slight increase in bleeding risk because you're on 2 antiplatelet therapies, but the overall event reductions were substantial. And based on that and subsequent trials with other molecules, dual antiplatelet therapy is indicated in all ACS patients for at least 1 year, unless contraindicated, unless they're having bleeding issues or other complications that contraindicate that. That extends across the spectrum of STEMI patients, non-STEMI patients, unstable angina patients, those that have been treated medically or revascularized percutaneously or even surgically revascularized. Within the first year after an ACS event, they should be on dual antiplatelet therapy. At the 1 year mark, most of the trials ended, and that's often where we stop the second antiplatelet at the year mark. This curve I've shown you before, but we know that when we stop that antiplatelet at a year, events continue to accrue with time, and within 3 years, as we've talked about, as much as 15% events occur again. So in some patients, we need to think past aspirin alone. It may not be enough to reduce events. Unfortunately, we did do trials looking at just continuing the dual antiplatelet therapy for a prolonged period of time. And all of those trials, if you put them together, there's really no significant mortality reduction by long-term dual antiplatelet therapy. It does have some event reductions in terms of non-fatal MI or non-fatal strokes, but comes at a significant bleeding risk by having dual antiplatelet therapy for a prolonged period of time. So in the vast majority of patients, after a year, we stop the second antiplatelet. There are some specific patients that may have very complex disease that required complex percutaneous intervention or had very high thrombus burden at the time of angiography, where dual antiplatelet therapy may be recommended for as much as 3 years. But in the vast majority, we do stop it at a year. But that does result in increased events, atherosclerotic events. So we tried to look, okay, beyond dual antiplatelet, is there something else we can do to reduce events beyond aspirin alone after a year? The COMPASS trial, again led by McMaster University, that we were a part of, did randomize patients to a strategy of 2 pathway inhibition, antiplatelet therapy to reduce platelet activation, and factor 10A inhibition to reduce thrombin production and subsequently fibrin production and reduce the thrombin fibrin platelet clot. And the hope was that this may be more efficacious than aspirin alone. So low dose rivaroxaban, not atrial fibrillation dose, not the 15 or 20 milligrams, but 5 milligrams twice a day of rivaroxaban plus aspirin versus aspirin alone was studied in the COMPASS trial. And in the COMPASS trial, we did see that there was as much as a 25% relative risk reduction by the combination of low-dose rivaroxaban with aspirin versus aspirin alone. It did, however, come with a significant increase in major bleeding risk of about a 1% absolute increase in bleeding risk, but the event reductions were quite substantial. the event reductions were particularly substantial in those that had peripheral vascular disease or those that have polyvascular disease, meaning disease in multiple vascular beds. If they have coronary disease and peripheral vascular disease, or coronary disease and cerebrovascular disease, then the combination of rivaroxaban at low dose plus aspirin had much greater efficacy than aspirin alone. And this combination is covered by Ontario drug benefit for the polyvascular patient, those with multiple vascular territories of disease, as well as the peripheral vascular patients. And some of our vascular surgeons in the region really do emphasize its use in the peripheral vascular patient. We have to be cautious, though, that it does increase bleeding risk, and risk benefit patient by patient should be considered. Now, could we just think about using a more efficacious antiplatelet than aspirin as a single antiplatelet rather than aspirin? Could we use a P2Y12 inhibitor like clopidogrel? This was assessed recently in the host exam trial. So this was a trial out of South Korea where patients were randomized to aspirin versus clopidogrel a year after their PCI. And what they showed in the host exam trial is that clopidogrel as a single antiplatelet a year post-event, so where you no longer require 2 antiplatelets, the clopidogrel group had a significantly lower event rate compared to aspirin alone. And in the secondary outcome analysis, this clopidogrel group had significantly lower thrombotic events, MIs, strokes, ischemic events, but importantly also significantly lower bleeding events. So those that were on clopidogrel had significantly lower, particularly GI bleeding rates versus those that were on aspirin. So we have now a proven therapy that may be more efficacious over the long term for both thrombotic event reduction, but also importantly, lower bleeding events. So this was shown in the host exam trial, and there has subsequently been a very large meta-analysis referred to as the Panther meta-analysis, where P2Y12 inhibitors were compared to aspirin in CAD patients. And in this meta-analysis, you can see that particularly ischemic and hemorrhagic strokes were reduced, more MIs were reduced, and the net clinical benefit was persistent across a spectrum of outcomes in those that were on the P2Y12 inhibitor, primarily clopidogrel versus aspirin, lower bleeding risk, less thrombotic risk. So many of us now, after a year of being on dual antiplatelet therapy, will preferably stop the aspirin and continue them on clopidogrel, because these studies would suggest that there's less thrombotic events and less bleeding events. So to conclude, we now have therapies beyond our traditional 5-pillar model. There is significant residual risk, and we now have a number of options available, which can make it complex at times. Who do we put on other vascular disease modifying therapies beyond aspirin, statins, and ACE inhibitors? Who should we be adding ezetimibe to? Who should we be adding PCSK9 inhibitors or modulators? Who should we consider for icosapent ethyl? Who should we consider for SGLT2 inhibitors? Who will benefit from GLP-1 agonists and vascular dose rivaroxaban in certain patients? Who should we consider them for? But we should never forget that lifestyle interventions, cardiac rehab, and smoking cessation should be a central part of ASCVD risk reduction. It makes it often complex. As you know, Cambridge Cardiac Care Centre runs one of the regional cardiac rehab programs, and it is a nurse-based initiative, and it can become quite complex for the team to really ascertain what best to do next. So based on that, we tried to develop a management and risk assessment guide for our team. It's now available for anyone to utilize on our website. The link is below, cambridgecardiaccare.com/calculator. So this is a risk assessment guide and management guide with an AI-based platform to help guide next therapies. We studied this in a pilot study that we did at our center. This web-based AI algorithm was developed in combination with the University of Ottawa Heart Institute as well as McMaster University, and we just published an pilot study with this to demonstrate its ability to both define risk in ASCVD patients, but also define next strategies to reduce the risk. So it is a relatively simple calculator online. You have to enter in very simple baseline patient demographics, gender, age, smoking status, diabetes status, their BMI, number of vascular beds, timing of their event, whether they have CHF or not, or atrial fib or not, and whether they're on statin therapy or not. The calculator then will develop the estimated 20-month risk of the patient having another cardiovascular event or cardiovascular death, and compare that to patients that may be on optimum therapies beyond traditional therapies. How much can you further reduce that risk by intensifying the various therapies that we've talked about? So it gives you that potential to talk to the patient as to, these are the further event reductions that we can achieve with optimizing your therapy. And as I mentioned, it has an internal AI algorithm for risk factor modification recommendations. So not only does it give you the estimated risk of the patient, the AI algorithm underneath will help to determine what best to recommend to that patient. So this is the background science behind the AI algorithm. It then develops online the recommendations as to what to do next. So for example, in this patient, it recommended cardiac rehab, but it may recommend smoking cessation strategies and specific smoking interventions to consider, anti-lipid therapies, triglyceride therapies, all of the therapies that we've talked about. It's developed so that you can print the results into the patient's EMR and print it for them to take home. It also has a citations tab so that you can see where the citations, the trials that actually lead to those recommendations. So I'll conclude now by saying, I think we've come a long distance in our understanding of ASCVD and the disease progression of atherosclerosis. It is a systemic process, and we really need to take a coordinated systemic approach to event reduction in this patient population. But fortunately, over the last few years, very exciting and novel research has demonstrated that beyond our traditional therapies, we have newer therapies that can further reduce events in certain patient populations. And by deploying that, hopefully we can continue to reduce the disease burden, as this disease continues to be an epidemic across the country, and now worldwide is the leading cause of death, even more so in countries like in Asia, in India and China and Japan, where event rates are continuing to accrue at a very alarming rate. So globally, we need to have very effective strategies, and certainly in our own jurisdiction, we need to make sure we're deploying these therapies effectively. So I'll, at this point, stop talking and open it up to any questions that may be from the audience. Sorry, Jenny, can't hear you. Sorry, I am not able to hear.
Hi, Dr. Pandey. So Jenny is not able to unmute, but thank you very much for doing the grand rounds and doing it last minute especially. I'm just wondering if anybody has any questions for Dr. Pandey at all.
Hi, Shakur. This is Shazia. I just had a question. Thank you. That was a great talk, by the way. I just had a question. With the greater efficacy for clopidogrel and less complications, do we switch our secondary prevention patients that have been on ASA long-term to clopidogrel?
So we have been doing that at our center. Preferably when we're stopping the second antiplatelet, we often stop the aspirin and switch to clopidogrel. and even in patients that have been on a longer term, I am switching a significant number of them. A host exam came out a few years ago and really demonstrated that about 3 years ago that there was good benefit. And after the Panther meta-analysis in particular, which is a huge meta-analysis showing that consistent benefit, it's interesting. An agent that's both more efficacious at thrombus prevention, but also more efficacious at lower bleeding risk. It's pretty unique to find that. So, yeah, we have been preferably using Plavix or clopidogrel over aspirin. Thank you for that question, Shazia.
Hi, Dr. Bandy. This is Ashraf Sefin. Thank you so much for this interesting talk. Can you please give us an insight about the importance of use of GLP-1 in diabetics for primary prevention?
Yeah, so you know this much more than I do, Ashraf, but I think GLP-1 agonists, both in secondary but also in primary prevention, show very important reductions in both cardiovascular outcomes as well as renal disease progression outcomes, and have very low rates of hypoglycemia. So certainly they have anti-obesity properties. I think there's a lot of efficacy from the use of GLP-1 receptor agonists. I referenced briefly the SELECT trial. We will have data now in the non-diabetic population as well for cardiovascular prevention with GLP-1 receptor agonists. We were part of trials looking at GLP-1 agonists in heart failure with preserved ejection fraction, HFpEF, and again, both in diabetics and non-diabetics with HFpEF, GLP-1 receptor agonists may reduce disease burden and symptom complex and may have benefits in that HFpEF population as well. So they really seem to be having efficacy across a broad spectrum of cardiovascular risk patients, both those with established diabetes, but also importantly now, very good data coming together that the non-diabetic population that's obese and at risk may benefit from the GLP-1 agonists. So, to me, anyone who's at a significant risk of cardiovascular events and is diabetic, GLP-1 receptor agonists and SGLT2 inhibitors really should be cornerstones of diabetes management in that patient population.
Thank you.
Dr. Schaefer, I'll let you have the last question.
Okay, Shaker, thanks very much. A wonderful talk as you always give. A little bit beyond the scope of this, but after all the discussion about prescribing antilipids, at what point do we deprescribe? At what point in a patient's life does it not become beneficial?
Yeah, excellent question. So, certainly as we're all hopefully living longer and longer, we're now seeing our patients into their 80s and 90s, and that does become an important question as to, where is the point that we need to start deprescribing, particularly in the extremely elderly population. They tend to have polypharmacy. To me, statins are in particular incredibly efficacious agents that reduce both MIs, but also importantly strokes. Very good data on primary and secondary stroke prevention. The Sparkle study, for example, I didn't have a chance to talk about, looked at patients that have had strokes and showed that those that were on statins or specifically prescribed statins compared to placebo, even in the extremely elderly population, that trial I think included patients up to the age of 90, continued to have reductions in strokes, and there was actually lower rates of dementia in those that were on statins for secondary prevention. So, I think it really comes down to, if they've had an atherosclerotic event, I think if they have a significant enough survival, I would still think that they should be considered for ongoing statin therapy. But if they have the comorbidities, their life expectancy is very small because of malignancy or renal failure or some other condition that will be life determining and is a very short time window, then perhaps that may be something to rethink whether there's enough efficacy. But if they have a few years of expected life expectancy, even if we're not particularly concerned about extending life, reducing strokes and reducing particularly multi-infarct dementia reductions that we saw in the statin trials, I would think personally that should be maintained. In general, statins tend to be well tolerated, and really very little evidence that they cause harm in any meaningful way in an older population. So unless the life expectancy is very short, where we don't think that there will be much of a benefit, if there's enough of a life expectancy, personally, I think that there's still benefits to be accrued.
Great, thank you. So thank you everyone for attending. Thank you especially to Dr. Pandey for attending during very much a busy day. If you have logged in by phone, please just let Nina know you are here so we can track your attendance. And everyone have a great day. Thank you very much.
Thanks so much, Jenny. Thanks everyone for attending. If there's any questions, you all have my email. Just send me an email. Happy to respond at any point offline. Have a good day, guys.